So this was what we did here is in the context of a study we've already presented results of the role of dose-adjusted EPOCH-R to treat patients with adult patients with Burkitt lymphoma. And we've shown that this approach cures virtually all patients with low-risk disease. And in those with high-risk disease, the 5-year event-free survival rates are over 80%. So it does a good job, but it doesn't cure everybody. And so the issue is, how do we identify patients that have higher risk Burkitt lymphoma? And when we had first published our paper, we had shown that, traditional risk factors such as age of the patient or presence of HIV, that those didn't seem to impact outcomes when you use dose-adjusted EPOCH-R. Subsequent to our publication, there had been a much larger effort in a retrospective study of real-world cases that developed an international prognostic model that was focused on 4 features in Burkitt lymphoma. And so they published this showing that if you had high-risk features, which was 3 or more of these findings, which were related to serum LDH, the age of the patient, the performance status, and presence or absence of CNS disease. If you had 3 or more of those, you were high risk by the international prognostic score. So we wanted to look specifically at the same features that were in the BL-IPI to our multi-center study and see if they also applied. So we took their model, and what we showed was that the BL-IPI did indeed risk stratify patients on our prospective study, but each individual factor in the BL-IPI was highly prognostic when you look by itself, except for age. So age was the only thing that didn't seem to have much of a prognostic impact, at least in the prospective study we had done. So we wanted to look a little bit closer at, this relationship between the BL-IPI and CNS disease. And what we found was that the BL-IPI, when it was high risk, but they didn't have any CNS disease, those patients all did very, very well. But the opposite was not true. So if the BL-IPI was low or intermediate and they had CNS disease, those patients did relatively poorly. So at least in our prospective data set, it does look like presence of CNS disease, presence of bone marrow disease, presence of peripheral blood disease, those seem to carry more prognostic weight than just age alone. And so that was the main point of our study. And really what it gets to is how we're going to prioritize studies in the future and who are the truly high risk patients or the unmet clinical needs. And I think a lot of them are going to end up being these patients that have disease that involves the CNS.